So good afternoon, good evening, everybody. I know they have pushed breast, mammography purposefully to the end of the session, okay? Because you guys are tired and you don't have any interest in mammography. My PGs sitting there are smiling. Anyways, so I don't have ample of cases like how, other examiners had. We will deal with only 2 cases. Then you tell me if you want to read more or no. Okay, and this is going to be complete interactive session. There are no, the word format slides and all that. Okay, so you guys have to interact with me because I know this is a subject which all of us, push it to the side. But let's see how we do it about it today. Okay, case 1. And all the boys are going to participate in this, okay? No girls. So this is a 28-year-old lady, okay, who presented with a just a 1-week history of painless palpable lump in her left breast. And on clinical examination, she had a hard swelling palpable in the upper outer quadrant of the left breast. So what do you think should be done for her? What should be the first line of investigation? Tell me. I have to act like an examiner, proper examiner, Loud. We have to wake up. Ultrasound. Okay. So we did ultrasound. Okay. So you guys know that ultrasound, there is when we do a mammogram and when we have a mass, we have something called BIRADS. Are you guys all aware of it? BIRADS was the first, the system which was invented. Okay, after that only your PIRADS, LIRADS and everything came. Okay, so now who is going to read this ultrasound? See, the basic thing is that if you go home after seeing these 2 cases, you don't have to read breast again for your exam. Okay, so tell me who's going to read this. Somebody wants this mic. Dr. Kalpana, since I know you, so I'll tell you. It's okay. You just try it. It's a learning session, so there's nothing like I don't know or I'll say wrong or right.
It's a well circumscribed hypoechoic mass lesion with lobulated margin and no evidence of any calcification.
Okay, so we'll go line by line. She said it is well circumscribed. That was her first thing. How many of you think it's well circumscribed? Okay, see, first when we see a mass, okay, in breast, first thing is you have to see the shape. Okay, and now the latest BIRADS has made it very, very simple. You have only 3 shapes. It's either round or oval or irregular. Okay, so now tell me what shape is it? Irregular. So this is an irregular shape. Okay, then second thing comes is your margins. Okay, so margins, only 2 things, either circumscribed or non-circumscribed. If you are able to tell what type of circumscribed it is, okay, either it is angular or it is, spiculated, then you can tell it. Otherwise, you can just say it is non-circumscribed, okay. Now, what do you think, Kalpana, it is?
Non-circumscribed irregular mass.
Yeah, so the first thing is, like as she said, this is irregular, okay, and I'll tell you one thing, it is non-circumscribed. Somewhere I don't know what are the margins, okay, so margins are hazy, so it is irregular, non-circumscribed, okay. 2 things are clear now, okay. Now one thing I'll tell you people here itself, we get lot of fibroadenomas, okay. You people have seen that we have lot of fibroadenomas. So when we see a fibroadenoma, usually it should be oval, okay, but it is not the case, okay. In the book it should be oval, but most of the times we see they are lobular, okay. So what happens is, if you see 3 or less than 3 lobulations, you can still call it oval. So more than 3 lobulation, it goes into an irregular category, okay? But we have to give it only 3 shapes. We cannot give it microlobulated or lobulated word you should not use. It is not the terminology now, okay? So you have to give it as a irregular if it has less than 3 lobulations. If it has more than 3, you can give it as irregular, okay? So that's clear. Now another thing which we do is whether it is, next point comes whether it is parallel to the skin or not parallel to the skin. See, we say no, parallel, okay, the mass is parallel, but lot of people don't know whether it is parallel to what. You have to see it according to the parallel to the skin, okay. So you know, again, it's a known fact that if the mass is longer then wider, okay, they usually say, we used to read, it is a malignant, it is suspicious. So if the mass is longer than wider, then obviously it will not be parallel to the skin, okay. So usually suspicious masses, okay, we don't use the word malignant nowadays, we use suspicious. So the malignant masses or the suspicious masses won't be parallel, okay, or the irregular, ill-defined masses will not be parallel to the skin, okay. Then the fourth point what you see on ultrasound is echogenicity, okay. Now it can be a posterior enhancement or it could be an acoustic shadowing. Third, it could be a mixed thing, okay. So usually, you know, cysts are having posterior shadowing, right? And the malignant masses usually they have a acoustic shadowing, okay. You can read that anywhere, but if you report a mass in the breast, there is a BIRADS card which is available on internet. You can just download it or you can see it, but you have to, you know, define the mass according to these points so that wherever in the world your report goes, it is a standardized report, okay. So now coming to this one, we have this irregular ill-defined mass, and you can see a substantially, you know, high vascularity, okay. So now we have seen a mass in the breast. She's a 28-year-old lady. She says that she has seen it only for 1 week, and it is not painful, okay. This was the history. Now what else would you like to see? Elastography, okay. Now elastography is also included in the BIRADS, okay. So you have different machines, different values are there. You all know it is a strain or shear wave elastography. And then, you know, if it is hard, you have certain values, or you have a color coding, okay, blue to red, according to the machine, it depends, you can see it, okay. We can do elastography and we find it's a hard mass. What else you want to see in the breast? Sorry? Okay, there are no calcifications.
Vascularity.
Architectural distortion. Somebody is telling surrounding architectural distortion. So there is no surrounding. There is some architectural distortion here. If you see, okay, this and all is an architectural distortion. There is some surrounding architecture. This, all of us know that this is a suspicious mass. Okay. So now what else you will see? Axilla, very good. So you have to go, you never ever send the patient without seeing the axilla. Okay, never. Because I have seen in my career so many cases where, you know, only there are, you know, you can pick up the mass by seeing the axilla. There will be a small kutty mass which will be hiding in a dense breast, okay, but the axilla will be glaring at you, the lymph node. So never ever let the patient go without seeing the axilla. So this lady had a axillary lymph node which is suspicious. Now all of us know that, you can sit Kalpana. Now all of us know that, you know, when we see a lymph node, all of you know the difference between a benign and malignant lymph node. So in breast what happens is length does not matter. Length can be 10 centimeter. I have seen 6 centimeter, 7 centimeter. What matters is the cortical thickening, okay, and non-uniform cortical thickening, okay. Non-uniform cortical thickening means it should be bumpy, sumpy and all that, okay. Now what happened is after COVID vaccination, there was so much of difficulty in us to tell that this patient does not have a malignant thing and we should not put her into, you know, follow-up or anything, because, but most of the cases, 99.9% of the cases where the vaccination was done, the lymph nodes were found in left axillary, okay, left axilla, because most of the people took it vaccine in the left axilla, and they were uniform cortical thickening, okay. So anyways, suspicious, if you are thinking first what will happen is the cortex will start becoming thickened, then it will become irregular, it will be non-uniform cortical thickening, then slowly the fatty hilum will vanish, okay. So this is how you have to grade the lymph nodes. Now, this is the Byrides card which I was talking. You know, all of you can just download it, and we did it with this. This is how we read. Okay, if I start reading, then we'll finish this only. It will become a breast class. So you can download this. This is available. This is standardized. You can, read and write your report according to this. Okay, now I am giving you this history. That patient's family history is very strong. Okay, her aunt had a cancer breast, both maternal and paternals, and this is not a custom made history. This is a real history. So now what would you like to have? MRI. Okay, so this is her MRI. Can you believe this? Look at this. Okay, so this is her MR. So what do you see? Can anybody read this? And by the way, whoever is bored can please get out of this class also. This also I give you the opportunity. So see, first thing is, it is very, very, strange, and it is very, very astonishing to see that how her full breast, almost the entire breast is involved. Both the outer quadrants as well as the central quadrants are involved. Okay, only the medial portion of the breast is spared. Okay, and here what you see is, you see these round things. Do you see this? Is it clearly seen? Okay, so yeah, you are seeing these round things, right? So many round things are there. These are clustered rings, okay? This is a book picture of DCIS, okay? Ductal carcinoma in situ. This is called clumped enhancement, okay? So this is a very, very typical. This is the subtracted image, okay? And this is your phase 3 image after the contrast, okay? So you can see in both the images there are clumped enhancement, okay, clumped clustered enhancement. So this is very, very typical of ductal carcinoma in situ. And also when we are reporting MRI, when we see a mass, we become very happy. Hanji, we saw a very malignant mass, it is enhancing, okay, leave it. But nowadays the world is looking at lot of more things, okay. So if you see, very obviously you can see there is much more vascularity in this breast as compared to this breast. Okay, so you need to tell. Actually, if people are doing research work, they are measuring the diameter of the vessel. Okay, they are measuring at what time it is enhancing. Okay, they are measuring what is the distance of the length of the vessel which is going and supplying that mass. Okay, there are so many things, but this is just an a wider view of this, that you have to see it. Okay, so now what else? When we have seen this MRI, we have described the mass according to the Byrides. Again, there is an MR Byrides card. Okay, basically, see, why are we have to be, everybody says, my teachers taught me that we have to be a clinical radiologist. So we can be a clinical radiologist only if we talk the language of a surgeon. If I talk to the breast surgeon, whatever they know, I should know it, and what they are expecting me. Otherwise, everybody is telling, you have seen, they'll look at the film like this in front of the patient, and they'll think that they know everything. So we have to, we have to bring them back to us. So in this, what you have to give is, in this patient, it becomes very important to give the span of the lesion, okay? That what is the total, what is the actual span of the lesion? Span means what length of the lesion is involved. So you have to give the longest span. It will help us. First, it will tell the surgeon that the mass is so big, okay, it cannot go in for BCS, okay. Secondly, when the patient comes back to you after a kind of treatment, you have to take a longer dimension, okay. You have to say that how much it has reduced, okay. Usually you can't be taking 1, 2, 3. People can take that, but whatever is practically possible is the longest dimensions, okay. It has decreased or it increased. And then other thing which we have to tell is, it is not a multifocal mass. There is nothing in the other breast, okay. You have to tell all that. So what else, other things we do, all of us, that very nicely we have done this kinetic curve, and it is showing type 3 washout curve. All of you know this. Okay, and then we have done a spectroscopy, typical the peak of breast, choline peak is at 3.2 ppm. Okay, so you have to see it. So this is pakka 100% a suspicious mass. Okay, with these findings you can tell that it is an extensive involvement of the left breast involving the both upper quadrants as well as the central quadrant, with type 3 washout curve and spectroscopy showing at 3.2 ppm choline peak. Okay, so should mammogram be done in this patient or not? Why? Sorry? Tell me some students. Why it should be done? People in front are telling correctly, but you use why is mammogram more important? Yeah, so I told you this is a typical picture of DCIS, okay? So you have to see an calcified DCIS, okay? MRI won't show us the calcified DCIS. So to rule out the calcifications and extensivity, we have to do an X-ray mammogram. Then X-ray was done for this lady. Okay, it did not show any calcifications, and actually if you see it, it does not show mass also. Okay, so you can see that you can be betrayed if you would have just gone in. Lot of private practitioners I see, they just send the patient first for X-ray. They don't see the age of the patient. I think all of us are radiologists here, so we know that X-ray should be done only at the age of 40. Okay, but I have seen 20-year-old girls also coming with the X-ray. Okay, so if you had this X-ray, and if she would have gone to some general clinic, they would have told, oh, just like inflammatory, just given her anti-inflammatories, and the case would have gone. So anyways, no calcifications are seen, okay, in this, but there are some lymph nodes which are not seen clearly, but there is one hyperdense lymph node here which could indicate that it is a suspicious lymph node. So now her PET is also done. Why is PET done? See, another thing is very important thing here is practical point. We have to teach our referring physicians that PET and MRI are not same. Okay. See, we miss lot of lobular carcinomas. We miss small cancers which are less than 5 millimeter. Okay, on PET. PET has to be done for staging only. Okay, it has to be very clear. So any patient, nowadays, surgeons want to do keyhole surgery for everything. For this also, breast conservative surgery has become a fashion now. Okay, they want to do that. So if any surgeon wants to do breast conservative surgery, he should do an MRI of the breast. He is doing a very big mistake if he does not do contrast dynamic enhanced MRI of both breasts before doing your BCS. Okay, because you can miss multiple cancers, you can miss cancers in the other breast, which PET will not give us that much of information. PET has to be done for staging. Okay, so anyways, PET is done for this lady, and there was nothing else other than a mass and a one lymph node, level 1 lymph node. So anyways, the basic diagnosis has to come from the core biopsy. So the core biopsy was done for this lady, and histopathology was in chomediocarcinoma. Okay, chomediocarcinoma. Invasive memory type with the DCIS. And now very important is all of us should know a bit about IHC, immunohistochemistry. Okay, because the treatment of breast cancer will not depend whether it is invasive mammary or invasive lobular. It will depend upon your IHC. Okay, it will depend upon your IHC. So what are the IHC things we have in breast? ER, PR, HER2 and Ki67 they see. Okay, so IHC was done for her. Okay, luckily she was ER/PR positive. This is how the ER/PR slides appear if somebody shows you, and this is HER2 positive. Okay, so these IHC was done for her. So basically I wanted to put this slide to tell you people that now the diagnosis does not depend upon that. IHC is very, very important. Okay. And now you have seen all her pictures. Okay, as a radiologist, what do you think will be her choice of treatment? See, we should know, as I told you, we have to be a clinical radiologist. We should know a little bit about it. I'm not telling you to become a surgeon and do the treatment or medical onco. So what should be her treatment? MRM. Okay. She's just 28 years old. Yeah, see, she has to, you saw, it's almost the entire breast is involved, okay. So whatever, the actual treatment is that she has to undergo neoadjuvant chemotherapy, okay, to shrink the mass. Okay, then she has to undergo the surgery. And nowadays, NAC, neoadjuvant chemotherapy, is so good that the mass is totally vanished. Okay, we are seeing it in daily practice. So surgery is not the first thing. You have to undergo neoadjuvant chemotherapy. So this is her image which we saw. But before she went into for neoadjuvant chemotherapy, it becomes very important for us to put a marker now. Okay, we have to put breast markers. They're easily available in Chennai. Okay, I won't say India. They're easily available in our own city. Okay, so we can just call these people and get a marker done. Actual surgeons who are really doing a breast work, they will ask you if you can do a marker. Some surgeons, they want us to put 4 markers at the sides of the mass, at the periphery of the mass. Most of them, they put only 1 in the center of the mass. And if you have a axillary lymph node, like in this lady, they will like to put in the axilla also, sentinel node marker. In the sentinel lymph node, they would put a marker. Putting the marker is much more easier than even doing the core biopsy. It's just like a FNAC. Actually, if you see, this marker is loaded with the small clip. Okay, it will be bow shaped or spring shaped and all thing. It is a titanium marker. It is different markers. Okay, for ultrasound guidance there is a different marker, for MR guidance different marker is there. So what you have to do is you have to just place this needle under ultrasound guidance. If you are seeing it under ultrasound guidance, sir, that is going off. So, and you are seeing this knob piche, so you just have to push this knob, the marker comes out. So you have to put the markers. So this patient went in for 8 cycles of chemotherapy, okay, neoadjuvant chemotherapy, okay, leading to the total resolution of the mass. You won't believe this, look at this. So the best modality of choice to see the response to neoadjuvant chemotherapy in our country, you know, which is a poor country, okay, ultrasound obviously. So you have taken the mass size on ultrasound, you can keep following it after second chemo, third chemo, fourth chemo, you can see and see if it is reacting. See, actually, to tell you a thing, if we are really looking into the response of neoadjuvant chemotherapy, they say that if you do diffusion weighted imaging, okay, within 48 hours of the first chemotherapy, you will know whether it is going to respond or no. Okay, but this is high level work which goes in things. Okay, but here for us, practically, remember, we have to do ultrasound or at least an MRI after second, fourth and sixth or eighth before surgery. Okay, whatever is your protocol accordingly. So this was her ultrasound. You can see actually there is absolutely nothing when what we saw. Okay, it's just small fluid level here. Okay, just small thing. Okay, this also we are not sure whether it is mass or no. Okay, nobody can tell. So this is how amazing neoadjuvant chemotherapy is, and it becomes very, very important for us to put the marker, because if you see it now, nobody will know where was the mass. So only the marker will guide you to take out that area. And if anybody can see this, this is her post neoadjuvant chemotherapy mammo. Only one view was done for a purpose. Can anybody see anything here different? There is a marker here in the axilla. Can you see it? Here. This one? Yeah? So very important to tell that there is a marker there, which is which was the sentinel lymph node, because this also started, I don't have a better picture actually, because this was done outside. So the lymph node also starts looking like a normal lymph node. Okay, it will show a nice hilum, okay, and show a thin cortex, or it might not show anything. Okay, so that marker point is very important because they have to dissect that. She's a young girl, she's 28 years old, she don't want to lose her breast. Okay, so they have to do a surgery accordingly. So this is her MRI, post neoadjuvant chemotherapy, okay, which you see is totally normal. There is a complete resolution of the mass. This is now and this was then. Okay, so with this we finish our first case. So I think some teaching points you would have taken. We'll go to the case 2. So this is a 23-year-old lady who presented with complaints of bloody nipple discharge. What should be your first investigation of choice? Huh? Madam is answering. Ultrasound. Okay, why? Because one, she is 23. Even if if she was 43, I would have done ultrasound first. Why? हैं? थोड़ा ऊंचा बोलो ना यार, उठ के खड़े हो हैं? Ducts you want to see. Okay. See, what we do is when the patient comes, generally what is the practice is when patient has come, we'll say patient has to undergo 43-year-old patient. This is 23, okay, so we'll do ultrasound first. But if she was 43, the general dictum is patient has come for mammogram and she'll go into your mammogram suite and the radiographer will do mammogram and then she'll come out. What they generally say is if you have seen the patient's history and patient typically is coming with the history of any kind of discharge, okay, first do ultrasound because when they compress on mammogram, the fluid can come out. Okay, it's a very simple thing, but it will give you a lot of information if you do ultrasound before. Anyways, you are going to do X-ray, but you do ultrasound first, reverse your process. So this is what we found. Okay, so I'll only tell you, this is you are seeing basically a solid cystic lesion. It is more clearly seen here. Can you see this? There is a duct and there is a solid thing in between this. So it's a dilated duct with a solid component within it. Okay, and there is a vascularity. So what is your diagnosis? Intraductal papilloma. Okay, it's a very simple. I put simple case. Why? Because we'll come to it later. So will the mammogram give additional information in this? Again, yes, because we need to see the calcifications. Most of the papillomas, okay, especially the malignant or indeterminate papillomas, they are associated with DCIS. Okay, so very important because this is a very common complaint. Okay, next to the lump, the second complaint which patients come with is nipple discharge. So you have a special ultrasound techniques with which you can see the nipple. Okay, even sorry. Somebody said something? Yes, super. So we have a technique called standoff pad of gel. We have to put lot of jelly and then we can put a probe gently over it. You will be able to see the nipple and the nipple areolar complex, means beneath the NAC you can see the contents properly. And now we have this also available in market, okay, our market. Now I am not telling you everything which is London based or UK based. So these all things are available in our own India. So we can do this technique. Okay, then we can do a radial scan. Okay, radial scan is nothing but you have to do it from, you have to see how I am doing it. You have to bring the probe from the further end to towards the nipple. Okay, only thing is, see, if this is a nipple, if your probe is coming like that, you should just tilt it like this so that you are able to see that properly. Okay, radial scan is like a simple scan how we do. Okay, another thing is two hand compression technique. You have to hold the nipple like this, what you are seeing here. Okay, two hand compression technique, which is also very helpful in seeing the lesions or masses under the, see, this is how you have to hold and do it. Okay, these are very simple things which we can do. Okay, nothing extra is needed, but we should know about it. And then there is a peripheral compression technique. You have to compress it from the top or from the below. See, here I have compressed it from the top and you are doing, this is a compression technique. And the next technique is rolled nipple technique. This is very easy and very, it gives us a lot of information and it teaches most of the lesions we find on this, and it is very easy to do. Yeah, see how you have to roll the nipple. You have to keep your finger behind the, and this is how I have to roll. I have rolled the nipple and I am doing the scan. It's very simple, nothing else. Just put a glove and do it. See how the nipple is rolled over by a finger. See, this is how you have to do it. It's very simple. Okay, but do it and you will get very good results. And you will see the ducts like this, and contents within the ducts you will be able to see very clearly. So we saw that there was somebody told it was an intraductal papilloma. What else you would do? Somebody in front is saying galactogram. How many of you have done galactogram till date? Nobody. Anybody has seen it? Nobody has seen it also. Okay. So now actually ductography used to be a very well known technique for nipple discharge, but now nobody is doing it because of these reasons. It's an invasive technique. Extravasation, perforation we can do. Okay. And though the findings we can see like this. Okay, this is actually the same case. You can see a filling defect and papilloma because we are in institute, so we do sometimes, for our study purposes. So now what is happening is instead of ductogram, we are doing MRI. Okay, so MR has become no problem. Okay, and these are the advantages. This is why MR is used. And I am not telling it, with my own experience. A lot of papers have come which have told that conclusive. It's a meta-analysis which says that, MR is more useful than ductography. Then this was the patient's MR, contrast enhanced MRI of that patient, and you can see there is a beautiful duct here, a beautiful papilloma here, and there is a duct which is leading to that. What should be your next step? What would you do now? We are telling only on, radiology it is duct. But will your surgeon agree? We have to do, say it loud, biopsy. Okay. Now, is the biopsy enough for intraductal papillomas? This case I have put, just to tell you certain good new things which are happening now. So, what kind of ultrasound guidance you should do? Obviously, when the lesion is seen on the ultrasound, we have to do ultrasound guided biopsy. Okay. Now, what kind of biopsy it should be? Ideally speaking, in today's it should be a vacuum assisted biopsy, okay, for papilloma. Actually, if you have done a vacuum assisted biopsy or you have done a core, 2 cases only I told. If you do a core needle biopsy and you find it is a papilloma, again you have to give it to the surgeon, okay. They will go ahead and do a microductomy, okay. They will take out that duct. But now, vacuum assisted biopsy, vacuum assisted excision is very easily available in India. Again, India. Okay, I am not telling anything abroad. Especially in Chennai also, we have vacuum assisted biopsy at 5 or 6 hospitals. Okay, so you can refer the patient there. The patient can undergo vacuum assisted biopsy. It is nothing. Only your core needle biopsy hole is like small, like 14G. This will be 7G. Okay, so it is just like a nick 11G blade you have. The top of that, only that much hole. You can put your vacuum assisted guided biopsy in that and you can suck out the papilloma. This is the ideal treatment for doing the papilloma treatment. Okay, since we are talking about papilloma only, so I am telling you about papillomas. So this is another evidence based. Okay, so now there is lot of, when we do a core needle biopsy, instead of doing a vacuum assisted biopsy, there is an upgrade of the lesions. Okay, so vacuum assisted biopsy is the way to go for the papillomas, intraductal papillomas. This was an intraductal papilloma. I think we have to stop now. Stop, sir. Continue. Okay. One more case will continue. So this is another case which is very interesting. This is a 39-year-old presented with a history of lump, left breast, 3 weeks duration. He said continue. You want me to stop? Make it short and sweet. Okay. So this, history is very clear that the patient has an abscess. You can see also here clinically, patient had already undergone IND, and still she is having this redness here. The scar is also here. She comes to us again. Okay, and we see this. When we see this on ultrasound, you are seeing a sinus, and we are seeing lot of vascularity around the tissue, and we are seeing tentacle like projections. Okay, so when we see like this, we are seeing so many granulomatous breast disease nowadays. So much of TB cases we are seeing. Don't think that breast TB is uncommon. Every day we see it. Okay, so this is a typical picture of, you can suspect granulomatous mastitis in this case. Okay, you can see this a panoramic view that there is lot of involvement, and there are two sinuses over here. Okay, and mammogram, again you are seeing a mass here. Okay, upper outer quadrant. So what could be done? The treatment is also aspirate. Okay, but when you are doing a core needle biopsy for these cases, ideally speaking, you should aspirate also and send it for gene expert. Okay, you can send it for your culture. Okay, routine culture, and also for TB culture. Okay, though it will take 45 days, but by the time patient, if she's not recovering, you can always put her and the result will also come. So you have to do it. And now this was the final was IgM, idiopathic granulomatous mastitis. And the treatment option nowadays, we have recently started to inject steroid within the dilated ducts under ultrasound guidance. This is the latest treatment guidelines. Okay, lot of patients recover with that, but it has to be proved that it is not TB, it is only idiopathic granulomatous mastitis. With that, thank you very much.